Good evening, ladies and gentlemen. In this session and in this lecture, I'll be talking on the diastolic function, and we will see at the end few of the diseases in which to assess the diastolic function. Now it's only 15 minutes, so without wasting too much of time, let me begin with this talk. Well, actually, because I'm using my own clips and the figures of the patients, and my institute only permits me to use it for the teaching purpose. So I don't give permissions that it may be put on any kind of electronic media. Well, it was very, quite well known way back in 1923 that there is a difference in how the old man's heart works. And it was said that the rate of relaxation of the heart is quite as important as the systolic contraction. But it is only 2 to 3 decades since when the cardiologists have started putting some emphasis on this diastolic function. We know that diastolic function is actually an active energy-dependent process in which there is delinking of actin and myosin areas and the repumping of calcium into the sarcoplasmic reticulum. And in the beginning, it is the relaxation phase when the aortic valve is closed and LV starts to dilate. And then once the aortic valve opens and the flow begins from left atrium into left ventricle, then the flow and the amount is decided by how this LV is actually relaxing further up and filling up and increasing in the pressure as subsequent to this phase of filling. The general causes for diastolic dysfunction you will find are age-related. In all the ischemia that you will find, there is always diastolic dysfunction. In the cardiomyopathies, it may be associated with hypertension, it may be associated with valvular problem, specifically aortic stenosis. And the reduced compliance you may find with hypertrophy, myocardial fibrosis because of any of the reasons, altered collagen composition, restrictive cardiomyopathy, and it has to be differentiated from pericardial constriction. Now, what are the phases of diastolic activity? It is the 4 phases, distinct phases are there. And I will show you on this cartoon that you can see here the aortic valve closes and the mitral valve opens. So between them is the initial isovolumic relaxation time. Then there is a rapid LV filling which produces the E wave. Then there is a atrial contraction, which is the 4th wave here. Then there is the atrial systolic filling that completes the diastology. Between the rapid LV filling and atrial systolic filling, there is a period in which the pressure difference or the gradient between left atrium and left ventricle is nearly equal. And so you will find the flow nearly ceases or it is just a trickle. So this is the diastolic phase, and that we are actually, by the use of echocardiography, we are measuring certain of these flow velocities and how they are filling up. And so it becomes an easy, simple, accurate method of evaluating diastolic function. Otherwise, people have used the sonomicro catheters with very micro piezoelectric crystals that were placed inside the LV, especially in the experimental settings in animals, and they have tried to look into it. Now, diastolic dysfunction, when we talk about, then we say that either it is normal, and that too normal is different from the ages. For younger age and for the older age, the normal is different. Then there are 3 patterns. One is the impaired relaxation pattern, and that happens earlier in the phase. And then there is severely restrictive pattern that can be reversible or irreversible. Reversible means that if you reduce on the, you do some kind of Valsalva and all that, and reduce the flow into the heart, then probably you may look into it that what's going on, or you do some kind of a stress test and look into it that what is happening, whether it is becoming more restrictive or returning back to normal. And between impaired relaxation and this restrictive pattern, there is a pseudo-normal pattern. Pseudo-normal pattern means that what happens that LV is getting diastolic dysfunction. So what happens that left atrium has to work more, has to generate more pressure. And when the pressure in left atrium goes up, so that it maintains the normal flow across the mitral inflow pattern becomes normal, then it is called the pseudo-normal pattern. Again, you have to do some kind of stress test to look into it, whether it is really pseudo-normal, a normal or restrictive. So how do you measure these patterns for the diastolic function? We have here the flow across the mitral valve, which we call as the transmitral spectral Doppler inflow pattern. Then we look into the pulmonary vein outflow into left atrium to corroborate what is the pressure like in the left atrium in relation to the left ventricle. Then the tissue Doppler velocities, because it is the diastolic dysfunction is actually affecting the myocardium, and that is causing that the flow pattern changes. So if we measure the tissue Doppler straight away, then probably that makes sense. And then the transmitral spectral Doppler inflow pattern and the Doppler tissue pattern, when they are summated into a Nagua's formula, then actually it gives you more information. And then there is color MO transmitral flow propagation pattern. Well, we don't usually we don't use it because there are so many caveats where to put the cursor and what is the slope which we are looking into. So quickly we go ahead. Here is the measurement of transmitral inflow velocities. I think you people all will know that we put at the highest velocities, which are at the tip of the mitral valve, right? And then we look at the velocities. Here are certain patterns. You can see this is the early pattern, and this is the atrial pattern, and the diastolic phase, where diastology means the between E and A. You can say here that there is the pressure between left atrium and left ventricle has actually become normalized, so there is a no flow or less flow. This is the pattern, and that's how we gather it. And then we measure the EA ratio. Here it is 1.7. And we also look at the deceleration time, which is from peak to the nadir, and that we measure here, and we look at the patterns. Now, this is the summation of that. You can see the age, how it is different. E is always more than A. Ratio is like this, and deceleration time is less. It is not too less, it is too high. So it is like that. These are the pattern which we measure. This is the diastolic time, and this is the relaxation time to begin with. Now, these are the patterns that change accordingly. You can see here, and that the normal is like this. In the impaired relaxation, the diastolic time is more. A is more than E. In the severe dysfunction, you will find E is more than 2 times of the A, and DT is very less. In between them, it looks like a normal kind of pattern, but with a low deceleration time, very low deceleration time. So that is how we measure it. You can see here that's the cartoon which I have made, diastolic function impairment along mitral inflow velocity. So it is somewhat like a smiling face. Then there are other ones. Here A is more, here A it is 2.2. Again, you can see limitations for this. Again, load dependency, heart rate and rhythm, mitral regurgitation and aortic regurgitation. Now, when the diastolic function is increasing, we are looking at the pulmonary venous flow. You can see that we are looking into the pressure, what's happening to left atrium. And the pattern is like this. You look at the atrial reversal when the atria contracts, that whether it is high, it is more than the DE velocity. and the time duration is more, then it means it's very restriction. Otherwise, in the normal one, you will find that S and D are nearly equal, but when there is a relaxation problem, then S is more than D. That is how we measure. You look at the left upper pulmonary vein, very easy to find, in most of the patients, all the times, you can put a very good flow, and you can actually, don't put your gate here at the opening, but here inside, at least 5 millimeter inside the red zone of flow, then you measure. Here is how it is being measured, looks to be normal. Here again, that's what I have measured. They are nearly the same. This is the changes again. They are age-based changes occur. You can get it in the books, and that is how you actually look at it. This is the relaxation problem. Here it seems to be normal, but always remember, don't put all the eggs in a single basket. You have to measure many parameters together, and then you have to look into it. And also you have to look at the clinical condition of the patient. Here A is more than E. Again, here is the more than E. Now, the third component is the tissue Doppler component. We all know that we measure at the annulus, lateral and the medial annulus, and the machine puts up certain filters so that it actually looks at the amplitudes and takes away the maximum, the frequencies, gain adjustment is there. And then annular motion is, because it is Doppler, so you have to be very careful that it has to be in the line. That is what's important, means it has to be parallel oriented. Now this is the lateral Doppler. You can see here it is E prime, it is A prime. We can measure it. And then this is the medial movement, medial annulus points, you see. We are using a tissue Doppler, and then we are looking at it. So that is how we are there and how we interpret it. E is more than A. Well, impaired relaxation, E is reduced, but restrictive pattern, you will find the E and A both are reduced, very much reduced. So that is how it is assessed. These are certain of the parameters which we are looking into. Here E is more than A. Again, there's a S prime velocity. We can actually look into it. Then what happens that we integrate the mitral flow and the tissue Doppler. If E upon E prime means the ratio is nearly 5 to 12, then well, it is normal. If it is more than 14 or 15, then it is abnormal. And by Negua formula, you can calculate the pulmonary capillary wedge pressure. And it has held good in various studies and various, it has found to be a good parameter to look into. Now, so this is, I have shown you that how you calculate the pulmonary capillary wedge pressure, and you can actually make out what's happening. So it was 13. So you keep on doing it. Limitations again, sinus tachycardia, conduction differences, regional wall motion abnormalities. Transmitral propagation velocity, well, it is difficult. It means as the flow races across the middle part of the cavity, then you slightly reduce on the Nyquist limit, and you capture the slope. You measure from here up to the first change in the velocity, reversal of the velocity. And then you look into it, that if it is less than 50, then they say that probably it is relaxation, means the restriction. But still, there are so many caveats, and we are not using it. Supportive features, always remember, don't forget to look at the supportive features, and they are measure the LA size in 4-chamber and 2-chamber views, volumes, right, and put them on with the body surface area. Then the abnormal LA function, pulmonary hypertension, and tricuspid regurgitation. They are very important parameters to go along with other things. Now there are certain 3 or 4 slides I immediately look into. That what are the ASC guidelines of the parameters? These are the guidelines. Now, how do we look into it? Mitral inflow, we look at the EA ratios, all right? If it is less than 0.8, probably normal. If it is more than 2, then it is actually grade 3. In between, You look into the other criteria, E upon E prime, that what is the average and what is the medial part, TR velocity, and the left atrial volume index. If there are two, then it is increased LAP. If it is less, then it is grade 1. Similar, the new criteria, these are the parameters, which are the normal parameters. If there are 3 abnormal, then it is diastolic dysfunction. If they're all normal, then it's normal function. And you look into other supportive parameters. Well, if there is atrial fibrillation, then we look into the deceleration time, because they are all moving a lot. And if you are looking into the mitral inflow velocity, and look at the various at least 12 beats, and then you measure. Otherwise, these are the parameters, and these are the other parameters which we are supposed to look into. If there is mitral annular calcification, then E upon E prime becomes difficult. Then we are actually looking into the IVRT, means the relaxation time, and it's a ratio with the E wave velocity duration time, and also the difference between E and E prime velocities. Now, lastly, I must say that LV diastolic function actually should not be done in OR, because in OR, all our activities are affecting the diastolic function. Anesthetics, changes in heart rate and rhythm, cardiopulmonary bypass and cardioplegia, effects of inotropes, and PO2, PCO2, pH, which are moving. Reperfusion phenomena always occurs, and the placement of devices in and around the heart. Thank you very much for your kind attention. I'm sorry I have to rise a bit faster. Thank you all.